and it's going to be by interventional techniques for complex dural AV fistulas. It's also coming from Dr. Vipul Gupta from India.
Hi, I'm Dr. Vipul from India. First of all, I want to thank you for this, for me giving this opportunity. I would love to be in your country. It's a beautiful country. I visited before, but because of personal reasons, I've not been able to make it. So I'm going to talk about neurointerventional techniques in complex dural AVFs. 10 to 15% of AVMs are dural AVFs, basically arterial supply and lack of parenchymal nidus. Usually they're idiopathic. Sometimes they have a history of craniotomy, trauma, or thrombosis. And there's various classifications. There's Borden's classifications of dural AVFs. If I have to say, so basically aggressive durals of the veins in which there is sinus reflux or cortical vein reflux. For example, as shown in this beautiful diagram, when there is antegrade flow, it doesn't matter much. When the flow is retrograde into the sinus or into the cortical vein, that is where there is increased risk of bleeding and we need to treat them more aggressively. And this is another classification which is commonly used, known as Conrad classification of dural AVFs. Now, since I'm going to focus on the technique here, symptoms will not dwell for too long, but yes, there is a higher risk category and with vascular reflux, with the annual mortality of 10%, annual risk of hemorrhage of 8% in these patients. Now, management, the treatment is key, is complete elimination of AVF. Now, I'm very, very clear that incomplete treatment actually leads to recurrent of collateral vessels and persistent risk of hemorrhage. So, and one has to get the complete venous occlusion in these patients. And to me, a failure to completely occlude is a complication because secondary procedures are more complicated. Repeat embolization is more complicated because you have lost your good access in these patients. Previously, we have used glue. It doesn't work so well. Then came transvenous or direct puncture coils. And then, of course, when the Onyx came in, that was the major advance where we could achieve excellent cure rates as reported in literature in 70 to around 90% of patients. And some selected patients can be targeted surgically as well. So this was the first case of Onyx, which I had done around 15 years back, and hemorrhage. And then this was the dural AVF. Now we can see it's a deep-seated dural AVF near the vein of Galen area with a lot of cortical venous reflux. And then we could achieve microcatheterization selected, and this is the Onyx injection. And this was the first Onyx injection done in North India at that time, and with the beautiful outcomes. So what is the strategy? These Onyx are not even squid. They are terrific material. And the challenge is that we have to go close to the fistula, and then we can form a plug and completely penetrate the nidus, including the vein, while preserving the normal structure. So analysis and strategy is important. Now let me go to a more complex case. This is again a dural AVF. One can see again it's a deep-seated, but the feeder is a superficial artery with a very, very long course. Again, very minor vessels from PCA as well. Now, even such tortuous artery can be catheterized. As you can see in this roadmap view, we sometimes form a loop of the wire, micro wire, and over that we track usually a catheter-like marathon. And then the loop of the wire helps in moving through all these kinks more quickly. And sometimes one has to change the wire as well. And as we keep advancing, we could do very, very distal, go through this extreme multiple loops, and then reach close to the sides of the fistula. As again see a loop of the wire, I've changed maybe this is my second or third wire in this patient because otherwise there's a lot of friction. And once you've reached very close at the side of the fistula, we know the difficult part is over. After that, it's very easy to get a cure. We are right at the site of the fistula, and this is the Onyx injection. Then you can penetrate, as one can see, the artery, the complete network, as well as origin of the vein, and then this is a complete cure in this patient with a very high degree of safety. The final angiogram shows complete occlusion as well. Another patient had previously been embolized, so very, very small feeders. You can see middle meningeal artery, very small tortuous vessel. There is an IC small vessel, no good access in this patient. So how do we treat this patient? We do a 3D imaging so that we can actually try to see where all these small vessels are coming on, and using the 3D we get a 2D angle where we can catheterize any of this very small vessel. You can see a distal access catheter right in the middle meningeal and a very small vessel. Then we have been able to catheterize using that 3D, and then the injection shows network filling. We are slightly away, but still deep enough to get a very good penetration of the small vessels as well as the vein, as you can very well see. Once you get this vein and reflux into all other arteries, is absolute cure with complete safety. So to me, 3D guidance and high guiding helps in these patients. Sometimes again we get a lot of patients treated elsewhere. This patient, the middle meningeal artery had been closed previously and had developed a lot of collaterals. You can see massive collaterals with a high flow dural AVF. Even leptomeningeal arteries had come in. So how do you treat such a patient? Again, you track, this is from the opposite side. The middle meningeal artery was crossing the midline and supplying the left side. So we went from the right side, and again, using this high access and fine catheterization, we could go across the midline, and then we could reach the opposite side and do this injection. But this was a very large diffuse AVM, wasn't a complete cure. And then you can see there are feeders coming from the leptomeningeal artery. The arrow points, the above arrow points, a very small vessel, and then anastomosis sort of it forms a collateral route to a middle meningeal artery filling retrogradely there. And so this from PL vessel, we could go on to the dural vessel again with the detachable tip microcatheter, and then we could do, once you reach the nidus, you can do a very deep penetration, including the ways, to get a complete occlusion in such a challenging patient. If no good arterial access is possible, then you can go transvenous as well. Previously, we used to use coils, but those catheters are not so easy. So nowadays, we like liquid material, which we can use it. Like this patient, dural AVF, again at the petrous area, multiple small ICA feeders. The ECA feeders have been embolized, long cortical draining vein, no good feeders here. This is from the occipital artery. So we went through the straight sinus retrogradely into that vein, and then we could catheterize that complete vein to reach the stump here of the vein. And then once you do onyx injection, you can control the liquid material so that a segment of vein is occluded. Then retrogradely, we could inject whole of the AVM to get a complete occlusion. This is another patient of dural AVF at foramen magnum with brainstem edema. Again, very small feeders, and this is a very tricky area. You can't really catheterize. So this 3D angiography with vaso-CT really helps us to analyze. So again, we have gone through the petrosal sinus here, and you can see this first image is the AP view with a guiding high up, rightly hooking the sinus almost, and then retrogradely we could tear a detachable tip into the stump of the vein. And this is the microcatheter injection. Once you're there, it's pretty easy to inject in very quick time. Using detachable tip, we detach the tip and AVM is gone in a very safe manner. Another patient treated previously, middle meningeal artery, massive collaterals, no good arterial feeder, but the vein drained into superior sagittal sinus. So again, feeders from the pile feeders. In this case, we did a direct jugular puncture, and then we can see the guiding catheter is right in the superior sinus, and through that we had taken a catheter into the draining vein and could navigate right into the stump. In this case, this was high flow, so we decided to use two microcatheters, one for onyx and one for coils. So the coils will help in the control of the onyx penetration. So this is one microcatheter. Then we placed through the other, we placed these coils, and then we could inject the dural AVF completely to get a complete cure. So yes, transvenous route is very useful, particularly in some patients of this cavernous sinus dural AVF, because they will never have good arterial feeders. They will always from ICA and collateralization from ICA. So these cases you have to go transvenous. This is a patient with this massive proptosis and large sinus, and this was the feeders from ICA and ECA small feeders and dural AVF or the superior sinus. The vein appeared to be almost occluded. So again, we went for the posterior petrosal route, and then we could enter from there into the sac, and this is the sac injection. Once you are there, it's not so difficult. We usually inflate a balloon at times into the ICA and you can see the balloon inflation so that there is no reflux into the ICA, and then we could easily inject very quickly onyx or squid, whichever material you like, to get a complete occlusion in this patient. And you can see how quickly, within 2 days, he was so much more better. So how do we preserve? But when sinus is used by cerebral veins, is again a different channel. So how do we preserve sinus in this? Some high flow fistulas into the sinus and a critical sinus. And then what we use a balloon in the sinus. These are known as RC balloons, which are large diameter and they take the shape of the sinus as well. But we do inflation to check the control and 3D analysis to understand the anatomy completely. Like this patient with the dural AVF or the suprasagittal sinus, these are the vertebral artery feeders, massive cortical venous reflux, bilateral ICA, high flow, and you want to, if you inject here blindly without flow control, the material will go into the sinus, and we want to preserve the sinus in this patient. So how to do it? You can see multiple feeders, high flow. So we have inflated the balloon. You can see this is the first microcatheter injection. The contrast just flies off. Now we inflated the balloon in the sinus, and when we inject now, all the feeders fill retrogradely with no leak into the sinus. And this is the injection being done, progressive injection with the balloon inflated. Sinuses are quite diseased in this patient, so but these balloons take the shape of the sinus, the RC balloons from Vault. We really like them. And this is the final picture. You can see that the sinus is preserved. We have deflated the balloon, and this is the final injection, shows the fistula is completely gone. But one can clearly see from the IC injection the sinus is well preserved, and all the reflux is also gone. This is another patient with high flow dural AVF of left lateral sinus. The right sinus was anyway very hypoplastic. Multiple feeders opening at one point. You want to preserve the sinus from vertebral artery, from ICA as well. Massive venous congestion. You can see the right lateral sinus is not present, so you want to preserve that left sinus. So again, the RC balloon has been taken. We took 2 microcatheters for good flow control. You can see the 2 microcatheter tips there from right side and left side. And then when we do the injection, what we can see, the dye is not going into the sinus, but is refluxing to all the feeders. Now we have a very good flow control, and we could do very aggressive and quick injection to get a complete sinus reconstruction. The final angiogram shows that the sinus completely gone, and this is the final onyx cast. But one can see we have left a passage for the sinus within. And you can see in the lateral view also, down the barrel view, the sinus was spared. And this is the final angiogram. It shows that dural AVF is gone, but you can see the left lateral sinus is filling very well, and on the follow-up also it remained patent. This is another dural AVF of left lateral sinus, but again no good arterial access. And you can see some veins were opening near that side of the fistula. So sometimes we can do transvenous catheterization and a balloon, and then control the flow. This is what we have done. 1 microcatheter placed into that sac which opens in the wall of the sinus. So it is important to identify that sac using 3D imaging. Another microcatheter placed as well, and then the balloon inflated, 2 microcatheter tips seen. So we were right at the site of the fistula. There was no margin of error here. And then this is the microcatheter injection showing the fistula in the wall of the sinus, and then we could inject all of it all around, closing the fistula completely while preserving the dural sinus. This is the final picture, shows the AVM is gone, but the left lateral sinus is filling very well. Sometimes you can go transvenous balloon as well for onyx injection. So we have used septal balloon in the past, and now Eclipse 2L balloon for the same purpose. Right lateral sinus dural AVF. You can see the multiple compartments there, but what you can see upper and lower image, that the big cortical vein of Labe, it opens into the upper part of the sac. So you want to preserve that somehow. So we place a balloon there so that vein origin, the onyx material doesn't go. So we have done transarterial embolization initially, and then using the balloon from that lumen with the transvenous embolization. But we knew the inflated balloon will preserve the junction of the vein and the sinus, and the final thing, it is all gone, but the arrow points where the vein joins the sinus, that part has been spared by the balloon, and that is filling now normally. Ophthalmic involvement is challenging because these are ophthalmic feeders. They are not great for catheterization. We like to do transvenous, but yes, one can use ophthalmic route as well for embolization, provided you understand the ophthalmic anatomy. So this is a dural AVF, cribriform plate dural AVF, ophthalmic artery feeders. So we go transvenous, and you can see through that cortical vein carefully using detachable tip we can catheterize. We reach right to the stump of the vein, and then it's pretty easy to control the material. Once you get some control, then we can keep injecting very quickly. All the feeders have been filled retrogradely, and bilateral ICA shows the AVM is completely gone. This is the another patient, dural AVF, but transvenous route wasn't very amenable in this patient. And ECA feeders, bilateral ECA, ICA feeders, 3D anatomy showing the dural AVF in the cribriform plate. So we decided to transarterial. Once you go beyond the origin of the critical arteries in ophthalmic, that turn is there, which always is there. We can know that is safe, but the problem was very tortuous. We are not near the sinus, so we want to be very sure to control the reflux in this patient and penetrate distally. So we did what is known as pressure cooker technique. The green arrow points where the artery makes the turn. Beyond that, closure of ophthalmic is safe, because that is where critical arteries arise from. So we could go beyond that, and we place the coils so that no material reflux happens anywhere near this point, and then we could completely embolize the dural AVF in this patient. You can see some stitching of ophthalmic artery because of sudden flow change. We like to give heparin to all of these patients post-operatively. So in summary, most dural AVFs can be safely cured by embolization. Incomplete closure not acceptable. Strategy is very important. Strategies for access and venous control are the key. And insurmountable or challenging dural AVFs can be thereafter Onyx injection is pretty easy, but really they do need a surgery or radiosurgery as well. And again, I want to thank you for this opportunity.
Now we come to the last lecture from Dr. Muhammad.